Hello, my name is Dr. Pablo Castañeda, pediatric orthopedic surgeon at New York University. Thank you for watching this video, and thank you to the organizing committee for allowing me the opportunity to share my experience with office-based ultrasound of the infant hip. I have no disclosures that are relevant to this talk. So why is it important that we, as pediatric orthopedic surgeons, learn to use office-based ultrasound of the infant hip? Well, let's start with the fact that it is the single most frequent anomaly found in human beings. Depending on the report you read, up to 1 in 30 people have hip dysplasia. At the end of this talk, you should be able to interpret an ultrasound of an infant hip in 3 simple steps. Define how ultrasound helps identify the spectrum of pathology that makes up hip dysplasia, and explain how ultrasound can help you guide treatment. Another great name for this technique is POCUS of the hip, not because it implies magic, but this is the acronym for point of care ultrasound. This is a very simple technique that can be learned by any clinician and requires minimal setup. There are many probes which allow excellent visualization. They can be connected to a tablet or smartphone and allow maximal portability, providing a dynamic visualization of the diarthrodial joint that is composed of the femoral head and the acetabulum, with no risk and no discomfort to the baby. It also minimizes the amount of physical contact which patients and their families are exposed to, and minimizes their time spent in the clinic. These have always been important, but now more than ever. It allows documentation of the dynamic aspect while stressing the hip, as well as a morphologic assessment of the important structures that make up the joint. Measurements can easily be made, and immediate interpretation of the results is obtained by the clinician, who is ultimately the one who will be dictating treatment. As you can see, the images are clear and easy to interpret on this smartphone device, which allows easy capture and manipulation and can be exported to any PACS system seamlessly and wirelessly. Let me walk you through how to perform ultrasound of the infant hip in 3 simple steps and 8 seconds. The first step is determining the location of the femoral head in relation to the acetabulum. To keep it simple, we will only have binary outcomes. The head can either be located or dislocated. For this, the probe should be held over the lateral aspect of the thigh, while keeping the hip flexed and holding the transducer parallel to the shaft of the femur. By observing the position of the femoral head in relation to the acetabulum, location is determined. The second step is determining stability. Again, the outcome can only be binary, with hips being stable or unstable. By maintaining the position of the transducer and applying posterior stress, akin to a Barlow test, observe in this case how the left hip is stable under stress, compared to the right hip, which seems to come out of the back of the acetabulum when applying posterior stress. Here you can see it gliding behind the acetabular rim. The third and final step is determining the shape of the joint, and again, hips can only be one of 2 kinds, normal or shallow. It's easiest to think of this on the ultrasound as an AP radiograph of the pelvis, lying on its side, and if you're able to interpret this, you will be able to understand what you are seeing on an ultrasound in much higher definition, with no radiation and in real time. This is the view where angles are constructed and measurements can be made. The first and simplest is the percentage of bony coverage, which should be at least 50%. The second is the alpha and beta angles, which are measured by drawing a line along the bony acetabulum and measuring the angle between this line and the baseline for the alpha angle, and a line to the cartilaginous cover for the beta angle. The percentage of bony coverage should always be greater than 50%, and the alpha angle should always be greater than 60 degrees. The beta angle is less reliable, but should measure less than 55 degrees. Here you see once again determination of location of the femoral head. As it is touching the acetabulum, it is located, but it's found to be unstable under stress, and the morphologic view shows it to be shallow, with less than 50% coverage and an alpha angle less than 60 degrees. Hips with any degree of pathology, whether it's dysplasia, instability, or dislocation, should be treated. In keeping with the binary theme of this talk, hips can either be determined to be normal or abnormal. Normal hips do not require treatment. Abnormal ones do. Follow-up can easily be done. Even in a Pavlik harness, there is no obstruction to access of the probe. As far as efficacy, ultrasound has proven to reduce parental anxiety and reduce the amount of time spent in clinic. Both of these result in an increase in patient satisfaction. We know that the sensitivity of ultrasound is far superior to any other diagnostic test in newborns. As far as accuracy, in this soon-to-be published study, we found an intra-class correlation of 97%, meaning that providers across different levels of training agreed 97% of the time on this binary outcome of a normal or abnormal hip. POCUS of the hip is not magical thinking. It is the most effective and accurate way to follow patients with hip dysplasia in 2020. I hope you have enjoyed this talk, and I look forward to any questions and discussion.